So for the sake of time and for all of you who are so diligent to jump on time, we appreciate that. Really excited about today's webinar. Thank you very much for attending and helping us to kind of both hear from a couple of experts on their work, as well as start to kind of think forward, think ahead to what we want to accomplish within the Male Engagement Task Force, and kind of set some agenda with a little survey at the end of this webinar. If you'll go to the next slide, please. So you're going to notice some beautiful faces on this slide right here, and you're going to see some new beautiful faces. All right, so we're lucky to have, as some people transitioned off of our Male Engagement Task Force, we were happy to welcome Chioma, Abhijit, Eva, Lynette, and Beth Malu, who are joining us on the Male Engagement Task Force co-chair team, and helping us to coordinate both our activities as well as our webinars. And you'll see their names now and again on our different mailings and distributions that are going to go out. So just a few new faces and organizations, and just so that everybody's aware of some of these changes. You'll go to the next slide, please. Okay, so you all are doing your Zoom experts, as we know, and one of the things is that we want to make sure you are clear on who's here in the room and working with us today. So if you'll keep yourself muted throughout this process, but if you don't mind using the chat to introduce yourselves, write your full name, any personal pronouns if you'd like, as well as maybe your position and organization that you're working with. And it's always nice to see the display of countries and regions that are represented by our participants. So if you'd share that, it would be wonderful. So we're going to ask you you can use the chat throughout the course of the webinar. We are going to have a Q&A function, I believe, and that will allow us to kind of gather some questions. Maybe we'll ask one or two of those questions in the post-presentation period. But I've asked the presenters to kind of respond to those questions afterwards. So when we do put out the mailing, some of the questions that are asked, maybe Tim or Kate will give us some responses that we can then put into the mailing as a little bit more information that address some of the questions if we don't get to them in the time allotted. And if you have any assistance or technology issues, please let us know, and you can message to Lily, and we'll roll that up into try to help you as best as we can. Please go to the next slide. All right, so those of you who want to hear this in a foreign language, or not a foreign language, but your language, please click on the interpretation icon at the bottom of the screen and select your preferred language. We do have a couple of interpreters for you today. We're lucky to have them, and we appreciate their work. And we know that kind of just expands the reach of the work we're doing, and includes more people in everything, and it really helps. So if you don't mind clicking on that, we want to make sure you're included. And if you have questions, you want to write them in your own language, please do that. I'm not going to read them, but we'll try to answer them in the mailing that goes out afterwards. All right, so go to the next slide, please. So under the meeting controls, and if you're on a phone, if you happen to be on a phone, you can find your interpretation under the meeting controls, and you'll press the 3 dots and then press language interpretation. You'll select English or French and then click done. Okay. All right, so go to the next slide, please. Just to remind everyone, this is a little bit the kind of overview objectives of the Male Engagement Task Force. We explore how to better reach and engage men and boys in health promotion and gender equity. We focus on diverse health areas such as family planning, sexual reproductive health, MNCH, HIV, malaria, TB, and it's forever expanding into other topics as well. And things like mental health that weren't part of this conversation until we started doing this during COVID. And we're also engaging with research and programming to improve behaviors and outcomes across diverse health areas. Okay, so we're trying to hit a bunch of different topics and use the world of opportunity and methodologies to address those things. So please go to the next slide. And within this webinar, we don't always have a chance to come together that often, but when we do, We want to learn from you and share with you information that we find and we hope is relevant to the work you're doing. So we want to convene you all and just take the pulse of where we're at this moment in time and talk about where we're going. I want to check in with the members to see if you're interested in and what your expectations are and what your needs are for the network. And also to compile priority issues and to see what types of things you are prioritizing in the coming year as it relates to male engagement and the work you're doing. And then also, we're going to talk a little bit in the first presentation actually is going to be Kendra, who's going to talk a little bit about the strategic assessment that was done a little while ago, which you kind of maybe prime your pump for some of the things you want to see happening in the coming year. All right, so if go to the next slide, please. Our agenda today. So as soon as I'm done, we can move on to Kendra, who'll talk about those survey results. Then Tim will present his recent policy review out of focus. After that, if we have time, we'll ask a question or two that comes up either in the Q&A or something relevant to the policy brief. We'll pass it over to Julie, who'll introduce Kate, and Kate will present her research around the men and their engagement in the health sector and how they're accessing HIV services. And then we'll have a quick conversation with Kate around some questions clarifying any points or interests in her work, and then we'll move on and transition into the questionnaire and learning a little bit from you about your goals and objectives. So go to the next slide, please. And right now, I think we're going to pass it over to my colleague. Before we get to Kendra, I think my colleague Erica is going to share a little bit about a new resource for you. And I'll pass it over to Erica, please.
Thank you, Dominic. Yeah, I just wanted to share very quickly in 2 minutes a brand new resource that Breakthrough Action has developed. This is the Male Engagement Compendium. This is an online resource of male engagement tools. We really focused on practical tools, so training tools and manuals. This is not about peer-reviewed literature. It's really for implementers. So in total, we have 47 resources in this compendium. You can search and filter them by these fields at the left, which include language, region, country, primary audience, and technical area. I will say that the region, country, we have identified a specific country if that tool is developed for a country, but our hope for all of these tools is that they're really adaptable to your context. So please feel free to, filter through and explore pretty widely. We developed this by lots of searching and crowdsourcing. We wound up with a list of over 80 resources, and then a team of subject matter experts reviewed and sort of coded them based on all of these criteria. We wound up including documents, materials that were fairly recent, so published since 2009. They had to be available in either English, Spanish, or French, although many are available in lots of other languages. And we were looking for tools that all refer to the no care do theory of change, which we highlight quite a bit throughout the compendium. We did sometimes on the family planning SRH scope to be able to include some broader topics that we didn't want to exclude those just because maybe they didn't have family planning in the title. Kendra, if you want to click on any of the individual resources, we can just show folks what an individual entry looks like and what's included there. Each entry includes a brief description of the resource. It also includes the region or country, the primary audience, the technical area, and the SBC approach. And then we also have the no care do theory of change. So we have identified which of those both components of engagement and role in engagement the resource addresses. And actually, I want to flag that everybody should look at their own computer because I actually think this is catching on an older version of the format. I think this is not current. The brand new one is up now. So please do look at it. I'm going to drop in the chat the link. It's on the Breakthrough Action website under the technical area of male engagement. So it's pretty easy to find. And we hope this is a useful tool for you. That's it from me.
That's great. Thank you, Erica. That's excellent. And I'm glad this resource is ready to be out and available to folks. We'll see how that's utilized over time. And, hopefully it facilitates more innovation and work that can happen as a result of having those resources and seeing what other people have done, implementing and building on that and tweaking things for local context. So with that, pass it over to Kendra, if you don't mind reminding us of our survey that was implemented a little while back.
Yeah, thank you, Dominic. So every year, or for the last 2 years, we've done a Male Engagement Task Force global survey that we send out to members. And we've had a response rate of 10 to 11%. So in this past year, we had 44 respondents. And I'm just going to give you a brief snapshot of some of the results. So in general, we want to get an idea of what our members look like. So who are they working for? What are their roles? And so this is just the results from the survey that we launched earlier this January. So in general, most members are either working for a non-governmental organization or academic institution, and or are a consultant. And then their typical role within these organizations is to be a program implementer, a manager, a researcher, or to be a consultant. And this breakdown has been the same between the global survey that we launched in 2023 as well as the one that we launched in 2024. One thing that has shifted, so we have asked in the past 2 years, have you participated in a Male Engagement Task Force event? And in the survey results that we received from the previous year, we did have a higher participation rate of 78% of members. However, it has slowly dipped, but I'm sure that's due to people now going back to work and traveling again. And so there has been a lower participation rate, but still fairly high at 66%. And then we also ask members what health areas or approaches are they interested in, and we kind of use this information to then guide what topics we discuss during our Male Engagement Task Force meetings and or to help us develop our knowledge products. And these results have been the same for the past 2 years. So high interest in sexual and reproductive health, followed by adolescence and young adult health, family planning, and gender-based violence. And we've also asked members what strategies or approaches are they most interested in discussing during our meetings, and gender transformative approaches and social and behavior change, which we're defining as community engagement, audience segmentation, behavioral economics, have tended to be of greatest interest to members. And then we left an open-ended question to understand, again, what subject areas people are most interested in discussing. And we kind of grouped them into these different areas. So gender, relationships, that includes dynamics, couple interventions, men and boys engagement, no surprise there, youth, diversity voices, which looks like having more youth participate or youth voices, or members from places outside of the US and Europe and Canada, collaboration, so networking, partnership, and coalition building, and then other, which looks like political economy of health and gender, SBC, cross-learning, advocacy and policy, which we'll discuss today. And then lastly, these are just some of the comments and feedback that we received from members. Many people are have provided positive feedback about the work that we're doing, but continue to let us know and look out for the survey in January of 2025. I'll now pass it back to Dominic.
Awesome. Thank you so much. And we will be, some of those questions you'll see at the end of this webinar, there'll be a few new questions and a bunch of new response options and some open-ended areas so you can give us your feedback. And this is a special community, and I appreciate that feedback and the engagement we get. We get great engagement in this group. And somebody who I'm going to introduce now, a friend of mine as well as a colleague, and also somebody who was with us as we restarted the Male Engagement Task Force a few years ago, is Dr. Tim Shand. He's worked as, I'm going to do his introduction now, and then he can take it away in one moment. but he's worked as an advanced policy practice and worked to advance policy practice and research on men's and women's sexual and reproductive health and rights for the last 2 decades. He's co-author of Shan Clark Consulting, providing technical advice, strategic support, and resource mobilization guidance to charities and non-governmental organizations working on global health and gender equality in some of the world's most challenging low and middle income contexts. His doctoral research focused on masculinities, gender equality, and contraception in Malawi. And Tim is an honorary research fellow at the Institute of Global Health and Development at Queen Margaret University. Tim has previously worked at the World Health Organization, IPPF, Sonke, Gender Justice in South Africa, Georgetown at IRH with me, Promundo, and now Equimundo in the United States. And he's spoken and published widely on men, masculinities, gender equality, SRHR, and Tim is also interested in better modeling men's health-seeking behaviors and understanding the costs and impacts of men's ill health on other men, women, families, and broader society. And he's going to talk today about a nice review that was done of SRHR policies, and I won't say any more. So Tim, please take it away.
Thank you, Dominic, and hi everyone. It's such a privilege to be back at the Male Engagement Taskforce to hear about the really exciting things that you're already doing and to share this particular piece of research. We were commissioned by Global Action on Men's Health to do a review on the extent to which men are represented in global and regional sexual and reproductive health policy, which is a report that you can see there. We launched it on World Sexual Health Day on the 4th of September. And really the idea of the report was to try to push the envelope a little bit, not only in the area of the traditional engaging men in SRH or men as partners, but really to try and more centrally focus on men's SRH for men's own needs, in terms of men's own lives, and try to think more broadly also beyond some of those traditional areas of sexual and reproductive health. We do focus very much on those, but really trying to think beyond HIV, STIs, and family planning in particular. And it complements 2 other reports that Global Action for Men's Health have produced, similarly looking at global policies. One on the very important issue of mental health that's just been mentioned, and also on cancer. And so I'm going to share a little bit of the background, and then I'll jump into the results. And then it would be great to think collectively about how we take this forward, and opportunities to work together. Next slide, please. We talk in the report around, as difficult as it is sometimes to calculate because of limited data, but nevertheless talk about men's unmet SRH needs in a range of areas. And we know, in relation to sexually transmitted infections, for example, that kind of rates for men are more common than women in all age groups from 25 to 85 of syphilis, chlamydia, gonorrhea, and trichomonas. In HIV, we now see a change in the pandemic where the greater number of infections are now amongst men, and we know in particular the challenges around men's access to treatment, testing, and the high rates of death for HIV positive men. And we know, and Dominic and I have worked on this together for a long time, around the need still to move the needle on men's engagement in contraception and men as contraceptive users. But we perhaps talk less about, in these conversations around fertility and the growing challenge around kind of significant falls in sperm counts, and male infertility contributing to about 50% of infertility in couples. There was a recent piece in The Lancet specifically looking at the potential impacts of fertility globally that you may be aware of. And I think it's a really important and timely debate around how we center men's needs within that. On sexual dysfunction, 50% of men aged 40 to 70 experience erectile dysfunction across several European countries. We don't have that data globally, but it nevertheless is a huge challenge that we need to think more about. And on male reproductive cancers, the prevalence of those have grown significantly since the 1980s, and so presents a really important picture as we think about policy to respond to men's SRH needs. Next slide, please. So we set out to really look at 4 key research questions. In that global and regional policy that's produced by the key public health, global health bodies, How is men's SRH included and how is it characterized? Did these policies include sex disaggregated data and measures on men's SRH? How do these policies discuss sex, gender, and gender equality, reflecting the comments that I just saw in your questionnaire as really important areas to understand? And how comprehensive was it in its focus on men's SRH? This was a rapid review methodology. We used a systematic approach to collecting data, to analyzing and then extracting the relevant components of the data that was included. And we had a working definition of men's SRH to guide us. We developed one. And we looked really at, as I said, the key public health or global health organizations that inform sexual and reproductive health. We looked at their websites, we searched relevant terms in relation to their websites. We then had a very clear definition of what we're including or excluding as policy. And it was a very iterative process where, as you know, when you find particular policies, they point to other policies. We also reached out to the Global Action for Men's Health Network, our own networks, to kind of seek other policies. And we were very deliberate that we wanted this not just to be a global north exercise. Much of the policies that are available and are more developed tend to sit in the global north. And so we really try to reach out and to look at many of the kind of regional institutions around the world, but also really trying to be thoughtful around the diversity that we reflect, not only institutions, but also donors and other organizations that play a really important policy forming role. We ended up with 37 policies. The report has a much more detailed analysis of how we did that. And we then analyzed those policies on a range of domains in relating to the areas that I've already mentioned, which I'll talk about in the slides. Next slide, please. We, as a result of the methodology and the initial reviews of policy, we decided that we wanted to really focus on these key components of men's SRH. And one of the things that we found was lacking was really a comprehensive definition of men's SRH. Many of us, we've worked on this area for a long time, including some really great definitions around men and family planning that have come from folks who are on this call and in the Male Engagement Taskforce. We centered on these 10 areas that we wanted to dive more deeply into in terms of policy analysis. So sexually transmitted infections, HIV and AIDS, contraception, fertility and infertility, sexual dysfunction, reproductive cancers, sexual pleasure, relationships, healthy relationships, discrimination, and violence. And the results of the report look at all of these different areas as we'll now explore. Next slide, please. So let's begin with the overall findings. So overall, reflecting what we found in relation to mental health and also the policy analysis on cancer, we found an overall insufficient focus on men's SRH within policy. So the majority of the policies, 57%, didn't sufficiently or at all acknowledge men's SRH. Of the 43% that did acknowledge, they tended to focus much more on at-risk groups, and they tended to also be far less comprehensive, as we'll talk about. And only 16% of the policies, so less than 1 in 5 of the policies, deliberately address men's own sexual and reproductive health needs or explored those particular needs in detail. A lot of the policies that did look at this tended nevertheless to be standalone, and a particular challenge is that there's often really excellent policies, say within the World Health Organization on this issue, but they aren't broadly integrated into the work of those institutions. We found an overall negative and instrumental framing for men, which won't be unfamiliar for many of you on the call, that didn't really look at men's SRH as a critical component of men's own lives and really took that more traditional men as partners, instrumental approach to working with men. And we found a very narrow focus overall, that they didn't address the broad range of topics that we were looking at in this review, and that there was very limited focus on particular groups, subgroups of men, as we'll come on to. That there was often a kind of general men and boys catch-all, but much less specificity. Next slide. A really important area to explore in policy analysis is not only what policies say, but whether policies include data and whether they have measurements and targets. And as we all know on this call, if something isn't measured and it doesn't have particular targets, it doesn't necessarily get prioritized. And we found only 14% of policies included sex disaggregated data. It was much more common that it would just be data on women's SRH. And only 14% of policies similarly had particular targets on men's SRH. And where those targets did exist, they tended to be more focused specifically on men having sex with men, or only in the context of HIV and STIs. And those are very important areas, but nevertheless, we would like to see much greater targets across the board to at a similar level to the targets that were found around women's SRH and policy. As mentioned, this is critically important because it leads to an inadequate understanding of the topic, but also far less attention. And it feeds back into that cycle where policies are then developed, which are not evidence-based, but don't sufficiently have a broader understanding of the challenges and needs that men have. Next slide, please. In terms of sex, gender, and gender equality, policies generally at a global and regional level failed to sufficiently differentiate between sex and gender, often use the terms interchangeably. There was insufficient acknowledgement of gender diverse individuals, and men's gendered behaviours and needs were largely overlooked, which won't be surprising for those of us who work in this area. And men were gendered, particularly in the context of their harmful behaviours and norms, which are really important to address, but nevertheless, there wasn't a more positive focus beyond that looked at men's own well-being, with the exception of men having sex with men as a particular at-risk male group. On gender equality, we importantly saw a strong focus on this within these global policies, but again, it was much more in terms of how to empower women, critical as that is, but less so about engaging men to accomplish gender equality and to address these unhealthy gender norms. And I think critically for us, there is a need for greater equity of SRH care, information and services for men. And policy doesn't make a connection between how addressing that inequity in care is actually good for the health, well-being and equality of everyone. And I think we need a much stronger focus on policy and recognizing that to improve the health and well-being of all, we really need to address these particular needs for men themselves. Next slide, please. So findings in terms of the specific topics now. Next slide, please. So in terms of STIs and HIV and AIDS, they tended to be one of the best covered areas within global and regional policies. So STIs in particular had either dedicated policies or were integrated into broader SRH policies. HIV, given the strong focus on that for now several decades, had well-developed policies. And they both tended to focus more on at-risk populations, in which we were including men, MSN, young men, people in prisons, injecting drug users, as well as transgender people, in addition to those groups of men. And there was only variable attention to people outside those groups. Young men often were mentioned, but there was very little specificity. And I think importantly, cisgender heterosexual men were often overlooked. And that's put a huge gap, given that we know the impacts of the pandemic on that group, but also that group as key drivers of STIs and of HIV, and the impact that those infections have on men themselves. And overall, there was a poor integration of these areas, HIV and STIs, within broader SRH policy. They were often standalone, very detailed, but has really provided missed opportunities to engage men in their broader sexual and reproductive health and for gender equality and women's empowerment more broadly. Next slide. In terms of something that I've worked on for a very long time, as has Dominic and others on the call, that contraception and family planning was largely framed in these global policies as a female-only issue, with the exception of really excellent USAID and other documents that we know about, which we talk about in the report. And we didn't really see a shifting in that kind of focus on kind of engaging men for women's uptake of contraception. And critically important as that is, but we haven't moved to really thinking about men as users within global policy. The male condom was the most widely emphasized kind of technology amongst male methods, but it was primarily in policy for its role in preventing disease and not as dual protection. Very limited focus on vasectomy, and no specific, or certainly a very insufficient focus on the potential that novel male methods provide to address this issue. Next slide. In terms of fertility and sexual dysfunction, only 16% of policies mentioned male fertility, with a predominant focus on female fertility. Fertility was not discussed comprehensively. It was only discussed in clinical terms, which is important when we think about the mental health issue. Male sexual dysfunction was entirely absent from the policies that we looked at. Only 5% of policies mentioned erectile dysfunction, and when that was mentioned, it was really largely in a list and in passing, with no focus on erectile dysfunction treatment or the potential for other underlying health conditions. We didn't see any addressing of premature ejaculation. And even though we know that sexual dysfunction is increasing in older and younger men, that was not addressed. And I think what's really interesting in this area is that, particularly in sexual dysfunction, we see a significant increase in men going to online providers for support, as we're also seeing in the kind of growth of kind of online providers around fertility. And often these are unregulated, potentially dodgy, if I can use that word. But because there's such a kind of blind spot and kind of nothing around this within policy, it really is a gap, which means men go elsewhere. And I think a critically, additionally important gap is that policies, when they look at this, don't think about the broader mental and physical health implications of infertility or sexual dysfunction for men, but importantly also for men and their partners and their broader families around them. So that's really was a key gap in the policies. Next slide, please. Male reproductive cancers were almost entirely absent from SRH policies as well, and when they were mentioned, they were not elaborated on. And that differed from female reproductive cancers, particularly cervical cancer, which received far greater attention, including dedicated policies and as part of broader SRH policies. And we're certainly not arguing that we should take the important focus away from female reproductive cancers, but we do need a greater focus at the same time on men's own reproductive cancers, given that significant growth that we're seeing. And I think interesting in this, we also looked at the non-communicable disease policies, not just SRH policies, because that's often where you find cancers. And again, at a global and regional level, NCD policies didn't sufficiently address male reproductive cancers. So again, a significant gap in policy around men's SRH needs. Next slide, please.
Just a quick note, Tim, we're coming close to time, so.
Okay, so just to say, in terms of sexual pleasure, relationships, discrimination and violence, again, an insufficient focus on all of those areas as opportunities to engage with men and also to support more healthy and equitable relationships. Next slide. And then the next slide again. And then the last thing on the results to say, and then I'll close, is just in terms of the particular groups. So when we look at young men having sex with men and transgender people, they're the best represented areas within policy. But nevertheless, we still found gaps on SRH needs around young men, insufficient kind of catch-all phrases around men and boys, as mentioned, and a kind of absence of looking at men having sex with men and their needs beyond the particular areas of HIV. Next slide, please. And then in terms of older men, disabled men, and men with serious health conditions, they were almost entirely absent from policy. So only 5% of policies specifically looking at older men, disabled men entirely absent, and the men who are living with or are survivors of serious health conditions similarly overlooked. So final slide, please, is really just to say, the overall recommendations is ultimately the need for a greater focus on men's own SRH needs, to expand data collection and to better address and target men and collect that data, to more meaningfully engage men in addressing these harmful gender norms, to have a more nuanced approach to men's own gender needs, to expand the focus on those other areas of SRH and continue to improve the focus on HIV, STIs and contraception at the same time, and really to be more sophisticated in the way that we think about men and really to target many of those male subgroups that are insufficiently addressed within SRH policy. Thank you.
Awesome. Thank you so much, Tim. And we have a moment we can actually, thank you for being on time and sorry to be pushing along here. We actually have a question that I think we should address from Kola in the Q&A, and I'll read it out quickly. So Are there any disparities in policies between developed and underdeveloped countries? If so, what aspects of men's health are most commonly addressed in underdeveloped countries, particularly in sub-Saharan Africa? So I think really kind of the point of, gets at also like where were the sources that you used? Where did they come from? Where didn't you see any sources coming from? And how does that kind of relate to some of the findings, and how the report can be used, I think, in the future too?
Great question. So I think a couple of things. I think one is definitely, as we think about sexual dysfunction, reproductive cancers, fertility and infertility, if you look at policies of the European Commission and European Union, if you look at policies from the WHO Europe, they are far more developed in those areas than, say, policies on the African Union, policies from the East Africa community, policies from Asia, even to some extent policies from Southern America, although PAHO and in WHO South America does have started to specifically look at that. But and there was a recent policy analysis that just came out in 4 East and Southern African countries, and that slightly dovetails our own analysis, which found similarly within those areas. So I think there is a big gap. I guess if we can be prudent in using that kind of global south, global north kind of split, global south policies do tend to have a bit more of a traditional focus on HIV, STIs, and contraception, and less of those broader areas. That said, at the same time, I think that global south policies are often increasingly donor-driven, and so you don't tend to have as nuanced a conversation sometimes around particular STIs that impact on men, which you have more of a focus on. So for example, human papillomavirus, there's been much more focus even in the UK and in Europe about the fact that we need to focus on boys as well as focusing on girls, as an example. Also in HIV, you often get better treatment and access for men in the global north than you may have a sufficient focus. And I think part of that is because the differing pandemics. And I do think in generalized epidemics, particularly in sub-Saharan Africa, where you really need a much stronger focus on cisgender heterosexual men, because policy is often being developed by the global north and donors and reflected in that, you don't have, and I know that there has been really important conversations within PEPFAR, within USAID about that, you don't necessarily have sufficient focus, if you look at the African Union or other African bodies, around the policies that relate to that. So I think there are really critically important gaps. I think part of the biggest gap, I'd say, is data collection. And unfortunately, policies in the global north have better data around men's unmet SRH needs than policies in the global south do. And I think part of that is just that the data isn't being collected in many countries, and so we simply don't know. So we couldn't tell you, for example, the higher rates of erectile dysfunction or particular premature ejaculation challenges outside Europe, because really that data, we were unable to find it. So yeah, I think a really important question, and I think it's something that is definitely worth continuing to think about. Thank you.
Yeah, thank you, Tim, so much for presenting today. This is a great report in review of those policies. I think it's something that those from donor organizations who are here today should take a look at and consider the implications of this in terms of implementing programming. And as this community has been building out the evidence to kind of show how engaging men also benefits women and children and families and communities, I think that's really important to understand the policy implications of increasing this work as we move forward. There are other questions in the Q&A. Tim may respond to them while Kate is talking, and as we move forward. If not, maybe he can respond and we can send those out with our session update that comes out in a few days or week, and we can hopefully address those questions because there are some good ones. At this point, I'm going to pass it over to Julie Pulowitz, who's going to introduce our next speaker. And so Julie, thank you, Tim, and Julie, please take it away.
Thank you, Dominic and Tim. Tim, it's great that you looked at all of those different domains in that report. Really useful. Thank you. This is Julie Pullerwitz from the Population Council and George Washington University, one of the co-chairs of the Male Engagement Taskforce, and great to see you all online. Good morning, good afternoon, good evening for those who are joining from different locations around the world. I'm really happy to introduce Dr. Catherine Dovel as our next speaker. Kate is an associate professor at in the Division of Infectious Diseases at UCLA and a technical science advisor at Partners in Hope, Malawi. Kate's a behavioral scientist whose work focuses on innovative HIV and related service delivery strategies in low-resource settings, largely for men. She's engaged in global policy development to improve men's engagement in health systems in the region, including work with the World Health Organization on the recent Men and HIV framework, which we'll be talking about today, which has been great to see come out, and looking forward to hearing Kate share the latest related to the framework. I should also mention she's the Director of Global Health Research for the Global Health Program at the David Geffen School of Medicine at UCLA, and she oversees and mentors a number of global health researchers for medical students and postgraduate trainees. So thanks so much for agreeing to join us, Kate, from the early, I think it's 6 a.m. or 5 a.m. in California. And I now turn it over to you to share the results. Thanks so much.
Thanks, Julie. Great to be with all of you. And yeah, happy to join in the early mornings, what you get for living on the West Coast of the US and doing this type of work. And my pleasure to be here. You can go ahead and go to the next slide. Today, I'm going to talk to you about provide kind of snapshots of different components of our work over the last decade, focusing most on the WHO framework for men and HIV. It's really men, HIV, and related services. So spreading a bit outside of HIV. And just to, I think it really dovetails nicely on what Tim just presented, diving in a little bit, giving you some case studies on why engaging men as clients in particular matters for men, but also for women and for the larger community, how health systems interact and influence some of these sex differences that we see, particularly with service utilization, and then exploring the WHO framework on what works, what are some options that can be done in practice. Next slide. Next slide again. Sorry, I'm slide happy, which for the person navigating slides may be a bit of a pain. Okay, so first, in terms of, like I said, I'll be focusing primarily on men's use of HIV services and sex differences within HIV specifically, but I think important to recognize that this is not a one disease concern, right? And I think a lot of you already know this, we don't need to spend much time on it, but we do see men bearing the burden of diseases across the SDGs globally. And so here's an important breakdown. Black lines are for male, blue lines are female. I think not surprisingly that we see men bearing greatest burden in areas of interpersonal violence, traffic, injuries, alcohol, but that we also see it for infectious disease under 5, which I think is, we really don't talk about much and hasn't been explored, reasons for why the sex differences are there, and then NCDs. So I think to Tim's point, thinking about this holistically across diseases is quite important. Next slide. Like I said, I'll be diving into HIV specifically, and within HIV, we see similar sex differences, particularly for HIV outcomes, but we're going to look here at service utilization that impacts poor outcomes for HIV. Here we're looking across the treatment cascade, so from testing, knowing one's status, actually being in care, or initiating treatment, and then becoming virally suppressed. Importantly, we see a range of sex differences by region. This is showing you the percentage points difference. So within Eastern Southern Africa, where I primarily work, We see a 4 percentage point decrease in men knowing their status as compared to women, and 8 percentage points for being on treatment or virally suppressed. I think really interesting is that we see highest sex differences in service utilization in Eastern Europe, Central Asia, and Caribbean, and the trend flipped when you look at Middle East. So certainly contextual, but across the globe, if you bring everything together, we are seeing worse outcomes for men globally. Next slide. Okay, so I want for us to start thinking about, and again, a lot of this is probably already covered. Hopefully we can share some new information with you that gives some other case examples, but why engaging men as clients is good for everyone. If we think about HIV, certainly it improves the health of men, which is critical to men's well-being and lives as individuals, which is important. Also improves health outcomes and well-being for women and families, communities. There's been a really fantastic modeling paper that was recently published by Manad and other co-authors looking at what would happen if we reduced the sex differences in viral suppression among men and women in Eastern Southern Africa. And what we find is actually, if we can reduce these sex differences, particularly in viral viremia, so viral load, we can reduce new infections among women by half. Here's a little graphic from their study. I think this, the lower bar at the very bottom shows you the contribution of transmission by male and female, and then the age ranges up above. And I think this is important. We focus a lot of prevention on women, particularly adolescent girls, young women, as we should. And I think this is a really great example of where if we want to reduce infection among women, if we're really pushing to improve prevention strategies among this key population, a major way to do that is to better engage men. And so thinking about it holistically. Then when we talk about general health services, if we intentionally engage men as clients, we can actually, within a health system framework, start shifting some of the gender norms, some of the social expectations around what it means to be a client, who should be a client, and shift the burden of care and caregiving away from just on women. And we're going to talk about this a bit in more detail with a case example from Malawi. Next slide. Okay. Yeah. Next slide. Thanks. Okay, so I want to talk now about some of the roles of health system, and we'll get into how health systems and engagement in health systems can impact some of the gender norms at a community level. So this figure comes from the Men and HIV framework from the World Health Organization. This is looking at some of the barriers that men experience, specifically for HIV and treatment services. And we see this triad of different barriers that come and intersect together. And I think that intersection, the triangle in the middle, is really key and is a key place to focus in terms of potential interventions. We have gendered health systems, which is talking a lot to what Tim discussed, right? It's looking at there are fewer policies, engagement points, strategies for men, which lead to, on the ground, fewer entry points, may lead to poor client-provider interactions, either because providers, or a combination, providers may not be trained and comfortable engaging men as clients. Men as clients may have assumptions and biases against providers as well. And so this interaction can have tension. And then we have a lot of limited messaging and specifically tailored interventions for men that create a real miss in their engagement. Harmful gender norms with feeling of hegemonic masculinity or harmful masculinity of needing to be strong, not seeking help, and then an uncomfortable feeling with attending health facilities, that facilities are women's spaces. And I think this women's spaces idea that we hear a lot of and is in our discourse is actually right in that triangle of a combination of harmful gender norms, but also perpetuated by our gendered health system. And then lack of social support, fear of social repercussions of seeking care. And then I think just to note, particularly in communities like communities in Eastern Southern Africa, other areas, this economic vulnerability around poverty, absolute poverty, is becoming more and more clear. This doesn't just affect men, also affects women, but affects men in differing ways, as there's the pressure on income generation and how that intersects with actually accessing and prioritizing care. Next slide. Okay, so we're gonna talk through then how some of this health system structure can influence care and practice on the ground. So you can see this is an adapted framework from a sociologist, actually, and you can think about the health system across 3 different levels. Policy, which Tim talked a lot about, and then how policy affects structure of how services are actually delivered, and then the practice of service delivery. And we'll talk a little bit about how these things come together to create the intersection and link between health systems, gender norms, and finally, use of services. Next slide. Okay, so this is also just another slide depicting this kind of trickling down or tie between health systems and practice and finally health outcomes. Really, we should have another arrow here that is connecting all of these back to each other. So there are feedback loops here, right? We have facility protocols and processes that don't have great entry points or inclusion of men, influencing our social norms. And in turn, those social norms come back and feed into perpetuating, continuing, changing our facility protocol. So just thinking about the health system and gender norms, gender norm transformation work as really tightly linked as we look to engage men. Next slide. Next slide. Okay, so I want to take a case study from Malawi. This is from a paper published in 2022 that myself and our colleagues did, and wanting to just talk about some of these entry points, right? So this is from Malawi's national guidelines on engagement and services, went through the guidelines and pulled out how frequently men and women are expected or encouraged to attend facilities. And we looked primarily at reproductive lifespan, so 15 to 44 years of age. So NCDs weren't included in here. Unsurprisingly, women, there are a lot of reasons women should attend or are expected, encouraged to attend a health facility, primarily around reproductive health services. But for men, we really don't have great entry points or routine entry points. Men are expected to come to the facility when they are sick, a broken arm, in our context, malaria, and it ends up creating really striking differences in potential exposure and expectations around how men and women act as clients. So here you can see we broke this up because a lot of women's use of services is around family planning, broke this up into type of family planning used, but basically women are encouraged, expected to attend facility anywhere from 170 times within this reproductive lifespan to 433, compared to really 32 visits for men. And so you can go to the next slide. This ends up affecting a couple different things. The social expectations around what it means to be a good client and an engaged client by sex. Also affects how frequently our time poverty potentially. So again, this burden on women, seeing women as primarily the client increases time burden on women. And here you can see a breakdown of this is same data, applying some time spent at facilities within any given year. You can see the hours that would potentially be required to access services as encouraged in those previous guidelines. Next slide. So as we're coming back to here, I think that I love that case study because I think it helps highlight some of these areas in blue, right? So thinking through the potential burden that is being placed on women as having them as a primary focus as a client. Not that we should decrease services for women, but including men in this, right? And that how inclusion of men within policies, within larger structures of health systems can help support shifts in our social expectations and gender norms of what it means to be a male client. Next slide. Okay, so I'm going to talk to you for the remaining of our time about what can we do about it? How can we include men within our health systems? And drawing from the WHO recently published Men and HIV Framework, you can see the link here. I'm also putting it in the chat. Yeah, I just put it in the chat, so you should be able to download it there. And because our time is limited, I'm going to go through this fairly quickly, but please take a look at it on the website. The full document is there, and I think it's really, hopefully, a helpful framing to think about how to incorporate men into larger health systems, individual programs across the spectrum. Next slide. Okay, what is the goal of the Men and HIV framework? Looked to provide again, this person-centered framework that incorporates synthesized evidence from a scoping review, and then identify remaining gaps. And we'll focus on the person-centered, the framework here, but again, in the document, you can see further discussion about the synthesized evidence from a scoping review and the gaps and next steps. Next slide. Let's go ahead and go to the next slide. Within the framework, the overarching principles about what it means to effectively engage men in HIV and related services, that service delivery, service strategies need to be inclusive of men. For this particular framework, we use a health systems lens and focus to be sustainable and that context specific. So all the different things we'll talk about should fall should be able to be adapted and tailored based on these principles. Next slide. Okay, so again, using a scoping review, looking at a little over 100 peer-reviewed published articles, we came up with, there's this person-centered care framework, and you can see it here, where there are 3 overarching pillars for engaging men. One is providing easy access to services. Key components of that you can see below in blue, so that there are available and dependable services, universal entry points, flexible services, and efficient. You will note right away that a lot of these core components are good for men, but they're also good for everyone. These are not necessarily male specific. What the framework does is deep dives into specific challenges that men experience that may need specific considerations or adaptations in order to provide these core pillars of person-centered care. So a great example would be entry points. We talked a bit about entry points up above, and that there is a real clear gap in entry points for just general engagement in services for men, and may require a male-specific response to help address that barrier. The second pillar is quality services. Again, good for men, good for everyone, as you see these 4 things listed below, but the framework goes into specific challenges around, I think positive healthcare worker interactions is a good example of, and why that may be uniquely challenging in different ways for men versus some other populations, and what can be done about that. And then finally, direct support. So this is providing usually time-bound, more intensive support around psychosocial, gender norms transformation, although I think gender norms transformation should be, can be, and should be incorporated across the 3 core components, and potentially a logistical support. Next slide. So I'm not going to go through these in deep detail, but just to say, I think one of the things we were just talking about is that the framework provides trying to really clearly detail what are male-specific barriers related to each core pillar, and then potential solutions. And so encouraging you to go to the link, look at the framework, and be able to kind of dive into some of these that really try to tie what are unique experiences for men and then unique ways that they can be addressed. Again, I think importantly, a lot of the solutions are what all clients need. And what I think is really encouraging about this is that it provides us opportunities to really integrate services, strategies for men within what makes sense services strategies for everyone. And so I think really thinking through that integration and not creating siloed interventions just for men necessarily as a way to promote scalability and sustainability. Next slide. Again, this is same. This is the barrier solutions for quality services. And next slide. You'll find the same for support, direct supportive services as well in the document. Next slide. What I would like to do in our remaining 2 minutes is come back to this link between gender norms, interpersonal interactions, and health systems. And so going to just talk through a bit of some case studies that highlighted the importance of compelling interactions of ties with healthcare workers. So this comes from Malawi. This is looking at over 90 interviews with men living with HIV who experienced treatment interruption and were offered a male-specific intervention that included male-specific counseling materials with a male provider and community ART distribution. Really fascinating at the end of the intervention. Among these 90 men that we interviewed, really prioritized actually the kind interaction, being treated as equals, being able to be like seen and recognize that that it's hard to access services all the time. And then having compelling messaging that really connects with men and their priorities and their lived experiences was actually more valuable to these men than having community-based distribution of services. Again, this is where the context specific comes into play, right? That may not be the case everywhere. Certainly, we saw that very strongly in Malawi. Next slide. This is in the framework as well, comes as a case study from Coach Mpilo in South Africa. Again, just so if this interaction between healthcare worker client is quite important, what are some of the challenges? And I think this table really nicely reflects some of the perceptions that healthcare workers hold about men as clients, feeding into some of what Tim was talking about the discourse of a negative discourse around men, that men are stubborn, they have too much power, they're indifferent, they're not wanting to engage. But that's actually not how men within this setting felt. Men actually felt anxious and afraid, that they didn't have people to rely on. They didn't feel seen as equals and trying to be engaged as clients themselves. So I think this is a really helpful framing and thinking about how we can help bridge this gap between healthcare workers and men. Next slide. And just to say, I think there are some real tangible ways we can work at addressing this that are fairly feasible, that don't, there's a spectrum of interventions across cost and feasibility. This is one example of a job aid that we're using in Malawi. I know there's something similar in South Africa with Coach Mpilo around how do we help guide healthcare workers to engagement. Again, you'll notice a lot of these steps are not just good for men, they're good for everyone. But helping healthcare workers break down ways to engage with men positively is actually we've found it quite empowering for healthcare workers. Next slide. And just to say, and go ahead and next slide again, there should be a pop-up. Thanks. Just to say, this framework is the beginning. We know, like Tim talked about, that getting evidence into practice is tough and doesn't happen quickly. So the WHO is working now on a implementation brief that gives some just very practical strategies about how some of these core pillars can be taken to scale within routine settings. Okay, I will stop there. Thank you very much.
Terrific. Thank you so much, Kate. I really appreciate, and we all really appreciate the presentation. You covered quite a lot. There's that framework. There's a follow-on that's coming up that we've talked about before with the case studies. I thank you very much. There are a couple of questions that hopefully you can answer along the way as we continue, but I thought I would just throw out one question to you because we all want to be sensitive as to time around what are you seeing as some of the distinctions or what is specific to HIV services and HIV programming as compared to some of the other topics. You've talked about the importance of integration, and I know there's a lot of standalone HIV services. So I wonder if you had any reflections around that integration and how we're addressing engaging men in services around family planning, around tuberculosis, around primary care, and what of these findings you think apply to other contexts and what might be specific to HIV. And you're currently on mute.
Thank you.
Thanks.
Great question. As part of the scoping review for the WHO framework, we did include services related to HIV. So STIs, family planning, there was a broad range. Again, like Tim found with policies, there was much less evidence coming out from non-HIV fields, not surprising. But the evidence that was there was some clear connection on strategies that would work across multiple health topics. I think a big one here, no surprise, would be just entry points. How do we initially reach men and provide points either within the community, within the health facility, where we're actually educating men on services available, the benefit of them, connecting with men's larger priorities in life and how using services helps them achieve their priorities. And then they can actually use care, right? Or use services. So I think that is probably one of the bigger ones. And then certainly on the direct support, being able to provide counseling and just one-on-one or just like interpersonal interactions that are meaningful and connect with men as clients. Yeah, those two kind of stand it out as the biggest that absolutely is needed across all of the different health services.
Great. Thank you so much, Kate. So I thank you again from the whole group, and I turn it back over now to Dominic.
All right. Thank you so much, Julie and Kate. That was excellent. I think, kind of getting at the message that, integrating men into these health services isn't just good for men. It's also good for women and families. And as Kate was mentioning in her presentation, a lot of those changes are changes that will benefit everyone in the community. So now we have a survey. We're going to ask you to answer about 9 questions. It's going to pop up within the Zoom itself. My colleague Marcella is going to put that up for you all in a moment. Some of those questions are multiple choice. Some of them are fill in the blank here. If you want to elaborate on anything, you can. But I would like us to, I know people have other meetings to go to and things, but I think this will take you about maybe 8 minutes, 10 minutes maximum. Maybe a few minutes more, but to kind of sit together, those who complete it and want to sit for a moment, maybe we'll open up the microphones for the last 10 minutes of our session and hear from you about what you want to happen in the future with the METF. And, if you don't mind, you can see these questions we're asking. I'll go through them really quickly, you can start answering those questions now if you'd like. but we're asking, it's voluntary. There's no mandatory fields here. So you can enter your name and your email address if you'd like. You can type the names of, please, 3 of the countries where your organization is working with boys and men. We want to kind of gauge and understand like where this work is happening. And so individuals can follow up. And also when we have opportunities for synergies, we can share those synergies more effectively. Also, how many male engagement events? We're curious about attendance. And some of you we see oftentimes, and others we see on occasion when the topic is relevant to you, which is great. But we'll take you whenever we can get you. Also, how relevant has the content of these events been to your work? We really want to know if we're hitting the mark for you in terms of the topic area so far. Not just today, but other events. Like previously, we had focused on the relationships for young adolescent boys. Other state-of-the-art events we've had in the past. We've had mental health. We've talked about other issues related to, the pandemic, when we were working through the pandemic and those things, and a variety of different topics that we've hit upon. Also, the 6th question here is, please name a topic you learned about through the METF that you've used. We want to kind of understand the relevance of this session, not just this session, but other sessions to your work. And then some topics you can select, and I've listed out a number here. Maybe I've missed something, but hopefully I've caught enough of them to make it relevant for you all. And then the last couple questions are also around strategies and approaches that are relevant to you. And we're curious, like if you were going to ask for some assistance for programming, what would that assistance look like? Is it content? Today we shared like the compendium, and we'll put those links in for you, and they'll come in the mailer that follows up with this webinar. But is it content like the compendium, or is it other things? Is it other content that you're interested to understand better? And how do we kind of help to facilitate that for you is really key. And then last, we talked about policies today and strategies. So does your organization have an actual male engagement policy or men and boys policy? And if so, we just want to know, and we'd love to learn more about that if possible. And then, as we think about the Male Engagement Taskforce in the future, we're curious to understand how you see our role in this work as we kind of move forward. So if you don't mind taking a few minutes to fill out that survey, I personally appreciate it. Our team appreciates it, and we'll put the results into one of our mailers and share it with you all afterward as well. We want to be transparent about this process. So if we'll sit together for a moment, and then we can open up the microphone and see if there are people who want to raise their hand and share. Someone has said they're not seeing the survey questions. So it comes in a pop-up window. So it could be that the pop-up window is behind your Zoom window. So please check that. Several can't open the form. Okay, Marcella, is there? Can you push it again? I don't know. Okay, so here's an online version of the survey in the chat. If you don't mind, if you're comfortable clicking into that and providing your answers then. Providing your answers through that page. Okay. Yeah, and if you have any questions or you want to make a comment, I see Lydia, were you able to get into the survey itself, or Olivia?
I think I'm using the link now. So I'm not answering from the link.
Perfect. Thank you, Lydia. I think that's who that was. If anyone has any comments or feedback around something they'd like to see and want to share it in the group, please go ahead. Okay, I think if no one is going to make any comments, I'm going to pass it back to Kendra to close us out, I think, at this point. Oh, Chaka would like to share. Chaka, you can come off mute if you'd like and share.
Thank you so much. Thank you so much for the very, very healthy, presentations. At least I'm happy. In the afternoon, just before I joined this, we were having, a conversation around health financing in Zimbabwe. And one of the members of parliament was saying that health financing should be it should be gender sensitive. And they were all talking about women. And they were saying that it should always focus on women because women have got sensitive and delicate needs. Then the only thing that stopped me from talking from that conversation is that I was the one who was doing the live streaming. But anyway, my point that I wanted to give as a comment is that we are neglected as men when they are talking about health financing, because there was the chairperson of the Parliamentary Portfolio Committee on Health who was part and parcel of that conversation. He never spoke anything about men's health, but it was just women. And also one of the panel was also from a women's and girls organization. But we have a lot of issues that are affecting men, and they are leading to suicide. Remember, we are also in September. We were talking about the Suicide Prevention Month. It is also the same month we are also talking about prostate cancer awareness. So you actually see that the issue around men's health is actually something that is not considered, not only in Zimbabwe, but in a lot of countries worldwide, where, these days they always come and they go and they are not even recognized. Just the same way we don't even have an International Men's Health Day, where we just, focus around issues of men's health, so that we have got that dedicated day. So I just want to give a quick comment to say thank you so much for this, conversation. And I think we do have a lot of advocacy points that we should push forward. Thank you.
Yeah, Chaka, one of the things that I hear you saying that I think is really important is language, and having the language to articulate why it's important to, whether it's increased service, access to service for men, and how that actually impacts and helps families and women and has better outcomes for everyone involved. Prioritizing women's health is not a problem, but just kind of making sure we have systems in place that provide access to health services for everyone will have a bigger impact for our overall community. And I think, we can work, I think, a little harder as a task force to also provide some of that language that helps both you and me kind of articulate this when we're in some of those meetings and sessions, which I think is a really important thing to think about in the coming year. All right. Thank you, Chaka. All right. So we have many people have dropped off. I don't know if anyone else has any other comments. If not, I'm going to pass it over to Kendra to close us out.
I actually raised my hand some time ago, maybe.
I'm sorry.
My hand was raised.
Olivia, please.
Yeah. One of the
Or is this Lydia?
This is me.
Lydia, okay. Thank you.
Yes, I've been doing work with men and boys for over 20 years. Actually, I would say about 30 years. And one of the things which I think we have never done, and it's like a joint learning. I didn't know whether we call it a joint learning initiative or joint learning collaborative, where we come together as people who work in the area of men and boys and share and bring learning practices and share our practices. Because we've had many joint learning collaboratives and joint learning initiatives. I've been part of one or two. And I think we need to come to that point, because we do take part in so many webinars on men and boys. I learn my little thing, I go in my corner, somebody learns a little thing, goes in their corner. But we've never had a real joint learning initiative or joint learning collaborative, which would be very useful for all of us to kind of come together and have this joint learning area. Because we for example, we've developed a very wonderful national strategy on men and boys. And I think one of the things we need to look at is how do we put strategies and policies into implementation and action. And these are things we can share. We haven't had those. Yes. So that's my only little point here.
Okay. Yeah, thank you. That's helpful to understand, like, what would be beneficial in your context is probably beneficial for many other people in their context as well. So that's really helpful to understand. And joint learning, and I heard you saying that it's going from policy to practice is really the key area for you at this point in time. So we can talk about that and advocate for that in our space, and you can continue to advocate for it in your space as well, with either the USAID mission or other donors who are willing to kind of support that work. But we'll push that up our chain as well.
I would also mention, if I could, Dominic, I would also mention that there is a Men and HIV technical working group that WHO and UNAIDS coordinates, which you probably are very familiar with. And so those are other opportunities for the kind of the multilateral. And Kate had we had a session.
I'm a member of that one.
Right, exactly. So that
we
might be able to. So we might be able to. We might be able to build on that and suggest to them as well some groups coming together. There might be a direction there as well.
Right.
Thank you.
Thank you.
All right. So Kendra, unless Olivia has a comment to make, I see she's the only other person with her hand up. And then Kendra can close this out. Oh. Yeah. Lydia, do you have another comment?
No, I finished. I'm trying to lower my hand, actually. Thank you.
No problem. Thanks, Kendra. Take it away.
Yes. Well, thank you all for joining and participating. Thank you to Tim and Kate for your fantastic presentations. I encourage you all to check out the resources that they've developed. We will be sharing links to those in the webinar recap that we will send out to all those who registered for today's event, as well as on the Male Engagement Taskforce webpage. So this is the webpage, and so this is how you can access information about past webinars as well as today's webinar and resources that we've developed. And there we should have the webinar recording, slide deck, and just recap available within the next week or two. Become a member. If you aren't already a member, please join our listserv. We send out a newsletter every month with resources, opportunities, and upcoming events that are in the male engagement field. So please join that and just be informed, and also contribute to the listserv by sharing resources that you've developed or come across. And that's all we have. Once again, thank you for joining us, and please stay engaged
Thank
in
you.
contact. Bye.
Thank you, Kendra. Bye.